Okay, hello, good evening everyone. مساء الخير جميعا. My name is Hassan Maghaireh. I'm very happy to be here with you today in this online congress. I'm here today from England, and I would like to share with you my short presentation on pink aesthetics in implant dentistry, surgical and restorative tips and hints. The idea is we're going to talk about how to achieve ultimate aesthetics in implant dentistry. We're going to present some surgical and some restorative tips and hints, hoping to get you the best of the best in restorative implant dentistry. So thank you very much for your attention, and I hope you enjoy this lecture. Okay, so pink aesthetics in implant dentistry, surgical and restorative tips and hints. First of all, I would like to present myself. I teach at the University of Manchester, Implant Dentistry. I also have a private implant clinic in Leeds, where I place and restore dental implants. But I'm also proudly the head of the scientific committee of the British Academy of Implant and Restorative Dentistry, BIRD. And there we have our mission to run courses to help our colleagues to promote clinical excellence through evidence-based education. We run courses in the United Kingdom, in Europe, but we also run courses in Dubai, Saudi Arabia, Bahrain, Qatar, and different countries in the Middle East. I would also like to take the opportunity to invite you to our first Congress in the Middle East, ILED 2018 Congress, which will be on the 5th and 6th of October in Dubai. It will be on implants, laser, aesthetic, and digital dentistry. We have a fantastic group of speakers, and I'd like you to be there with us. Okay, the challenge in implant dentistry, whenever we have a patient, basically the challenge in implant dentistry is not only about integrating your dental implant. It's about providing a soft aesthetics. You would like to provide pink aesthetics in implant dentistry, because only then you could have nice white aesthetics. So the challenge starts with getting nice pink, and if you get nice pink, it is much easier to get a good white aesthetics. So the challenge isn't about osseointegration anymore. Osseointegration challenge was basically in the past. Nowadays we know dental implants will integrate. The challenge is to make sure you place them in the right place, so they integrate in the right way, so then they can give you the satisfactory pink aesthetics, and then between you and your lab technician you could provide good white aesthetics. And what we'll do, we will focus on the importance of having good pink, because good pink, which means good gum, will give you good cosmetic work around your dental implant. But also we need to remember that good gum means good physical barrier to prevent bacterial ingress, to prevent bacterial damage to the bone around dental implant. The moment you lose bone around your dental implant, the dental implant will be contaminated, and then it will be hard to clean it. So the best treatment for a contaminated dental implant is to prevent having this bone loss and prevent having this contamination. As Belzer said, if you get pink failure, even using the most expensive abutment, the most expensive crown, will not save the case. So it's all about focusing on getting good pink aesthetics. That's the main challenge. We want to have a case when the patient comes to us with a failed tooth, we'll be able to place a dental implant in the correct 4-dimensional positioning, and then restoring it in a good way and having good white restoration, like this lady. Imagine if we had any tiny bit of recession in this case, it would have been embarrassing. And therefore, the whole idea is to take the tooth out, put a dental implant in the correct positioning, restoring it in a nice way, then you will have a good predictable soft tissue. When we talk about good predictable soft tissue, we're talking about soft tissue level, we're talking about the mesial papilla, the distal papilla, the soft tissue contour, the zenith of the gum, the alveolar contour, and then we're talking about the texture and we're talking about the color of the soft tissue. Only then you could be saying that, yes, I've got a successful case. And while there are subjective ways of checking your gum, I highly recommend going for the pink aesthetic score, which is an objective way. So in the pink aesthetic score, you look at the mesial papilla. Is it a full papilla? Then you score 2. If it's a flat papilla, you score 0. If there is minor discrepancy, you score 1. And then you do the same for the distal papilla, and then for the soft tissue level, and then for the soft tissue contour, which means the zenith, and then you look at the alveolar convexity. So alveolar convexity is very important because any implant with a flat alveolar contour makes it look very fake. A natural implant needs to have a nice convex alveolar contour. And then the soft tissue color and the texture. And when we talk about the texture, what we mean basically scarring. And this is something really important when you want to plan your case. Like a case with a thin gingival biotype, I would rather do vertical releasing incisions rather than an envelope flap. While a case with a thick gingival biotype, the moment you put vertical incisions, you're going to have more scarring, which will affect the texture of your case. So, this is what we want to achieve. We want to achieve a case with good pink aesthetics. The moment you have good pink aesthetics, it will be easy to restore your dental implant. And then from there, you can have a long-term predictability. We need to focus in the aesthetic zone that it is all about treatment planning. The moment you fail to plan, you plan to fail, and you're going to get aesthetic and functional disasters. Like in this case, this is a patient who had an implant in the upper lateral. It's fully integrated. It's a strong dental implant. But we both, appreciate that this is a failed cosmetic dental implant. This patient should have had a better pink aesthetics and a better white restoration. Any failure in the aesthetic zone can be catastrophic and very difficult to manage, and it's all about treatment planning. I would like to share with you this. It makes really big difference if we really understand it, and it helped me to focus on my work when I started my implant career. Any new skill we learn in our life, we go through 4 stages. The most dangerous stage, which is unconscious incompetence. You don't know that you don't know. You look at things at YouTube or on Facebook and you think, oh, this is easy. Let me do it. You try on your patient without good experience and you fail. And then your patients suffer. We all go through this stage. The best people who move quickly to the second stage, which is conscious incompetence. I know I don't know. Let's say I know I'm not good in sinus graft, so I go and attend courses, I improve my skills, or I refer complex cases to my experienced colleagues. So then they can do the cases they can, and I can do the cases I can, and my patients will get the most positive outcome. But then, as I said, I do something about it, and then you move to the third stage, which is conscious competence. You know what you're good at, and you do it for your patient with as much perfection as you can. But even better, moving to the fourth stage, which is unconscious competence. You're so good at what you're doing, but you're never too comfortable. Because the moment you're too comfortable, you start doing implants without surgical guides. You start doing sinus graft without CBCTs. You start doing veneers without having mock-ups. And that's when you might be lucky once, twice, but then third time, you're going to have a disaster. So let's start with this case. I will try to present a case from A to Z, and I will share with you my views in implant dentistry and how I managed to get pink aesthetics in my private practice in Leeds. This is David. David lost his 2 front incisors due to gum disease. So his referring dentist managed to fit him with a rochette. A rochette basically is a fixed temporary Maryland with composite pontics. And the idea is to try always to have a fixed temporary restoration, because having a denture will mean it will be rocking, and that means more gum recession. So whenever you can, try to aim for a fixed restoration. Now usually I would like to wait 6 to 8 weeks before I come back and place my dental implant. Before that, during this healing time, I will try to stabilize the perio condition of my patient. Like in this case, we put the patient through intensive perio regime to make sure that we stabilize his gum disease. And then we went ahead for his implant placement. So the CBCT shows us, as you can imagine, that we've got labial bone loss, especially on the right hand side, while on the left hand side the labial plate is still there. So you could appreciate that the right hand side one is going to be more challenging. Having a labial plate in implant dentistry makes big difference. So this is 6 weeks afterwards, and this is what I like to do, early placement, 6 to 8 weeks, because the evidence in the Cochrane library and so many different dental studies on dental implants suggest that the safest you can do from the placement timing is early, 6 to 8 weeks, during which the gum will heal really well, any remnants of infection will disappear, and you're not going to have unpredictable labial bone loss. So before starting my flap design, I would like to check the biological width around my adjacent teeth. If I probe and I find that I've got a pocket or loss of attachment more than 3 millimeter, I know the moment I raise that papilla, it will not come back. Because imagine now it's just attached to the root of the adjacent tooth by something like a scar. The moment I raise the papilla, it will re-establish its biological width, and I'm going to get recession around the roots of my adjacent teeth. Therefore, I always check if it's less than 3 millimeter, yeah, I can raise the papilla without a problem. In this case, as you could appreciate, using William probe, we have more than 5 millimeter loss of attachment. So that means my flap design has to preserve the papilla, and we'll show you later what we've done. Like here, we went for a papillary preserving siclar flap design, making sure it's 1.5 millimeter at least in this area to make sure it doesn't resorb. So the papilla, we believe, should be minimum 1.5. The downside of this design that it limits your surgical field, but the good thing about it, it helps you to avoid recession around your adjacent teeth. Now, yes, this was 6 weeks post-operative, but definitely you're going to open and find sockets. Don't think that in 6 weeks you're going to get any good bone healing. And that's according to the ITI classification. They call it like soft tissue healing, non-bone healing. So it's type 2 implant placement. So anyway, you raise the flap. And the trick here is to raise the flap, trying to get all the granulation tissue in the socket attached to your labial flap. So rather than cutting it, no, you raise the flap with the granulation tissue attached to the flap, which will help in making the flap thicker. So we use a surgical guide to show me where's my prosthetic envelope, to show me where I should place my dental implants, and then in the early placement, just like when we do immediate as well, we try to shift the osteotomy as palatal as possible within the sockets. So we do our drilling leaning on the palatal wall of the sockets, as palatal as possible within the socket, not too palatal, not palatal to the socket, no, within the socket. And then we try to make sure that we go tiny bit beyond the sockets to get some primary stability from the apical 1/3. We choose a dental implant which is not too fat. In the past, we used to think that we should use fat dental implants which put pressure on the labial plate to get primary stability. But we know now, the moment you press on the labial plate, this labial plate, which is made of cortical bone, will resorb, and then it will cause us trouble. So if anything, I am aiming for a labial gap. I want this gap. I want this gap to be there, because this gap, I'm going to fill it with autogenous bone, or if I don't have autogenous, I'll use some human tissue bank bone allograft, which will remodel into autogenous. Definitely, using xenograft in this area is not a good choice, because xenograft will stay hydroxyapatite xenograft for a long time, and then the implant will not be covered by natural bone. So the take-home message, make sure here that your implant is not a fat implant. In this case, I went for Straumann 4.1 millimeter implant. So I'm placing my dental implant 3 millimeter away from the future gingival line. So we place the implant according to our prosthetic envelope. We say, right, this is where the future gingival line going to be. 1, 2, 3, that's where my implant will stop. I will not sink my dental implant down to up there, because the deeper the implant it goes, then you're gonna get a recession. So from there, I've realized I've got exposed threads. I need to do some guided bone regeneration. But before that, I need to assess my soft tissue. So you could see here we've got a prominent frenum. And prominent frenum means there's going to be a lot of pull on the flap as it heals. That's why we do frenectomy, to make sure that when we've put the flap back together, as the patient moves his upper lip, there will be no too much pull on the flap margins. So you manage the soft tissue first, and then you move to the bone. In this case, I couldn't get a lot of autogenous bone, so I'm going to use some allograft. In this case, I used allograft max graft from Botis, and I'm packing it to cover the exposed threads, and I'm also packing it inside the osteotomy, in that gap, to make sure the implants are protected with allograft. The beauty of allograft that it will remodel into natural bone with a high rate, but the downside, it will not give me the stability I want. So I cannot use allograft to build the convexity. I have to use another type of bone to build the convexity, and in this case we use xenograft. So allograft to cover the implant and xenograft on the top to give me the convexity I want. And from there we go for a membrane. I try to support the membrane with a little pin, as you could see there. Here we go, that's a little pin on the membrane, because if the membrane will work really well, you need to have good convexity. Without that good convexity, everything will go flat, and the membrane needs to be stabilized. Studies have shown the moment you stabilize your membranes, you get better bone thickness. If you don't stabilize your membrane, there is a higher risk of bone loss even after grafting. So we stabilize the membrane, and I like to even get the membrane to cover my healing abutments, so then I'm grafting to a level even higher than my implants. Okay, we managed to achieve low primary stability, 20 Newton centimeter. So I will cover my implants completely, do full closure, and you can see here how we did the frenectomy, so there is no pull from the lip on the flap margins. I'm fitting my rochette in place, so I've got fixed provisional restoration. I told you dentures are harmful. We shouldn't use dentures in implant dentistry as a temporary restoration, because the rocking movement will give us gum recession, wound dehiscence. After 12 weeks, we get partial exposure, and that's the beauty of using 4 millimeter healing abutment. On one of them, partial exposure. On the other one, I find that I've got loads of keratinized mucosa, so I don't need to do big flap. I just use soft tissue trophine, and then I'm using a longer, narrower healing abutments. And from there, you can see we've got good emergence profile after 4-6 weeks. And then we put temporaries, and the temporaries job to get us nice soft tissue sculpture. We shave, correct the shape of the soft tissue using our temporaries, and we take impressions, and we fit our screw retained restorations. We like to go for screw retained restorations as much as possible, because obviously they're easy to retrieve, and we all know implants are not for life. Sooner or later, our dental implants gonna cause some trouble. They will cause problems sooner or later, so you have to think about plan B. And thinking about plan B is how easy is it going to remove the final restoration. If it was a cemented one, you're gonna struggle. Not to mention that we all know tiny bit of the cement can escape below the gum and act as a foreign body and give us peri-implantitis. So from there we put Teflon, and then we've got our screw retained restoration. I'd like you to have a look at the convexity there. We've got that convexity restored. If you remember the CPCT, we started there was massive labial bone loss. That's a final restoration, built in a nice cosmetic way. That's our 6-month follow-up, and that's the CBCT before. For those who have just joined us, that's we started with the defect, early placement, labial bone loss, and then you could see the dental implants, and you could see we've got more than 2 millimeter thickness covering our dental implants. The black shadow between these implants, this is just metal artifact, but what I want you to look at, that buccal bone covering my dental implant. In fact, if you appreciate that this is 4 millimeter implant, you could see the bone here is 3-4 millimeter. And I'm saying that because studies have suggested, like Spray et al. And Gundar et al., that any successful dental implant in the cosmetic region needs to have a minimum of 2 millimeter buccal bone for it to be long-term successful. Any labial bone less than 2 millimeter is going to resorb. Another case to finish with, this is Tom. Tom had a retained deciduous lateral, so this is a baby milk tooth lateral, which is resorbed and start to cause a lot of mobility. We went through different treatment options, and because the root was small and short, we decided to consider immediate implant in this case, just because basically there was no long socket and there was a huge amount of bone apically. So we placed the dental implant, trying to shift the osteotomy as palatal as possible within the socket, and we managed to place the implant at a torque higher than 35 Newton centimeter. And because of that, we thought, well, we're going to do immediate loading. So we fit the temporary abutment and we made a chair-side temporary crown. But now I'm going to show you the most important thing when you build your temporary crown. You need to design the temporary crown in a way that, number one, you get a good gingival seal, you get convexity supragingival and concavity subgingival. So this area needs to be concave. Otherwise, if it's convex all the way, it will push the gum and give us recession. And you need to have good contact points. Now you might think, right, okay, I've got the dental implant covered with bone. Do I need to do GBR? And the answer is definitely we do, because we need to build the convexity, the alveolar convexity we were talking about when we started this lecture. So a huge amount of soft tissue aesthetics is to do with the alveolar convexity. So even if the implant is fully covered with bone, you really need to build this convexity to give yourself the 2 to 4 millimeter buccal thickness. And then you put a membrane, and from there you suture nicely. These sutures have to be vertical mattress sutures, so the papilla is well preserved. A little trick, I always make my temporary crowns a bit whiter than the patient teeth. So you make them a little bit whiter. Within a week or two, patient come back wanting to whiten this teeth. So this is a good business. This is a good trick to encourage people to whiten their teeth. That's 1 week healing, and then from there, this is 6 weeks healing. Patient start to whiten his teeth. I want you to look at the convexity, and from there, at week number 12, the implant integrated with the bone, but at the same time, our well-designed temporary crown shaved the soft tissue for us. So you get bone and soft tissue healing at the same time. Here we go. We've got the nice convexity we're talking about. Yes, I've got a little bit of bone graft above the implant shoulder, which is even better. Dentistano call it dual zone grafting. And from there, we start working on the temporary, even better, because we have to shape the temporary and polish it. I don't touch the temporary during the first 12 weeks because the implant is integrating. But now after 12 weeks, it is safe for me to take the temporary, shape it more, polish it more. Now I'm happy with the shape of my temporary. I need to customize my impression pickup, because the impression pickup has to have a shape very similar to the temporary. So then the lab technician will know where the implant is, but also will get an idea about the soft tissue contour of around the dental implant, the supragingival and the subgingival contour. Here we go. The impression pickup is customized. Okay, the other lateral was a pig shaped, So we did prepless veneer and we took an impression. You could see how the customized impression pickup in place. CAD-CAM abutment, in this case we aim for screw retained, but the best we can do is to go for cement retained in this case. So if you're going to go for cement retained, it has to be CAD-CAM, because the CAD-CAM, you can put the finish line wherever you want it to be. You could design the abutment to support the papilla for you, but yes, this is a zirconia body but titanium base, so you get the best of both worlds. The upper right 2 veneer with the upper left 2 abutment. You fit the abutment in place, you fit the veneer on the other side, and then that's the implant in its place. And here we go, we managed to restore patient's smile and, more importantly, confidence, using, in this case, immediate placement, only because it was a resorb root, but more importantly, we managed to get immediate loading to help in shaving and shaping the gum the right way we wanted. Obviously, post-operatively, as you could see, a year afterwards, we've got 2.1 labial bone thickness, which is the most important thing. Because if we have 2 millimeter, then we know that we're going to have a stable bone and therefore no more bone loss and stable gum. Okay, I hope these 2 cases were useful for you. I wanted to share you some clinical tips and hints, and I would like to thank all my friends in this Facebook group for organizing such a fantastic congress. I hope this lecture was useful, and I wish you a great evening. All the best from United Kingdom, your colleague Hassan Maghaireh. Ma'as salama. We're wishing you all the best. Bye bye.